Thank you very much. So I am Dr. Christina Richards, lead consultant psychologist at the Tavistock and Portman Adult Gender Service. If you want to get in contact, I'm contact@ChristinaRichards.co.uk. Feel free. If you want to see my publications, I'm Christina Richards.co.uk. They're all listed there. And if you want to know my random thoughts about Brexit, then Twitter @CRichardsPsych is your place. Okay. So, I'm going to have a talk about counselling psychology. I thought, as I've just been inaugurated as chair, that would be a sensible thing to do. And particularly what it means to be a counselling psychologist, at least my idea of that. This may be a little bit challenging. Hopefully it'll give us a bit of zip in the afternoon. And it's a set of ideas to take away and to use and to think about. Okay. Now, I've written a whole bunch of stuff, I've written a few books, and a lot of these ideas are derived from my work, particularly within sexuality and gender, where there is a tension between sort of sitting with people and having people being able to express themselves, which is absolutely key. And then, of course, this idea about things like hormones and surgeries, where we are required to exercise power in assessing people for them, and how that could be a very uncomfortable position to be in, and how we can do that as collaboratively as possible. Okay, so counselling psychology. Who are we as counselling psychologists? We do a bit too much navel-gazing, perhaps, and we ask this too much, so I will flick through this fairly quickly. We are practitioner scientists. We hold doctorates. We have done research. We are able to do research. But we also sit with people in their difficulties, in their explorations, in their distress. So we're practitioner scientists. And we apply our science when we're with people, and we apply what we learn when we're with people to our science. We're qualitative and quantitative. We've done our undergraduate psychology degrees, which have that quantitative element, and hopefully that's gone on through masters and then gone on again into the doctoral work that we do. So we're able to bring in a number of different ideas about the world, a number of different ideas about how to interact with the world and measure the world into our work. We're both positivist and post-structuralist. We can look at logical, reductionist ideas of the world. We can understand them, we can critique them. We can also look at the messy edges of the world. We can look at post-structuralism or postmodernist ideas about how ideas can have fuzzy edges, how they can be contiguous. We can fit, again, these tensions in our work and in our science. And we're able to use power and to be aware of the use of power. Now, that idea of the use of power is sometimes an uncomfortable one for people who are counselling psychologists. We like to think that we're equal to our clients. But if our clients are paying us, and if we can say, well, that's the end of the session, or if we can cancel a session, or if we can move our premises, or if we can do any one of a whole load of different things when we're doing counselling, then those are the exercises of power. And of course, we will try and equalise that as far as possible, but we're kidding ourselves if we don't think that we're the people who are holding power in that room. We may be seeing someone with a great deal of more power outside of the room, but in that room we hold power. Now, that's only, of course, in therapy. We do other things as counselling psychologists. As psychologists, we do other things. And I'll come on to that. So what are we? We are all of these different things. And what that means is that makes us psychologists. We are counselling psychologists. And that's a very particular thing, a very precious and important thing. Okay. And we are informed by people with direct experience of what they come to us for assistance with. So we can hold the literature, and we can also hold those very personal, very important understandings that people bring to the therapy room, and hopefully bring within our science when we undertake our scientific studies, that we look at that direct experience in some interesting and complex ways. We hold statutory power, and this is where we differ from counsellors, because we are psychologists, we are counselling psychologists. We are statutorily regulated by the HCPC. With further training, we have a number of other things that we're able to do. We are able to section people under the Mental Health Act. We're able to be responsible clinicians for people. We're able to make mental capacity acts assessments. We can undertake psychometric assessments, mental state assessments. We're able to be expert witnesses and not just professional witnesses. We can diagnose. We can make referral for physical treatments, such as hormones and surgeries, as I do in my day-to-day work. And we can be an HM Courts and Tribunals service expert in the field of gender dysphoria, which allows you to create legal gender recognition reports. So we have a whole variety of statutory powers that are different from counsellors. It's not to say that counsellors don't do very important work, very, very important work, which we too do, but we do some other things as well. And these things involve the use of power. And when we use power, we must be cognizant of power. It's not enough for us to sit to one side and say, well, we'll allow the doctors to do that. We too hold doctorates. It's not enough for us just to say, well, I don't have any power, because even if you're not doing these things, if you're sitting down in a room with someone, there's still power in that room which is being exercised. So are we pretending to be medics? I have bought a pipe. No, I haven't. That's all right. Are we pretending to be medics then? No. We can bring a unique and collaborative philosophy and perspective to the use of power. Some models of the use of power require there to be one person to whom something is done and one person who does the doing. And that there are different classes of people. And I'm not proposing that that's the case for us here. What I'm proposing is that our understanding of intersubjectivity, our understanding of I-thou relating, our understanding of the fundamental humanity of the people whom we're dealing with gives us a unique perspective where we can still use power, but we can use it with another human being. And I think that's a really important perspective. It's not that we have this idea that we are intersubjective and that we have I-thou, but that there is no power there, and that in other circumstances there is power but no intersubjectivity. For us, we can be in that difficult, messy, complex place where these things intersect. So we need to be aware of the impact of power outside of its immediate framework. So not just I was told to diagnose with this the ICD or the DSM out there somewhere creating these new diagnoses. We have to be aware of the fact that when we're exercising power, if we are using diagnosis, what does that mean? Is that Procrustean? Does that take away the edges of people? If we ought not to use diagnosis, in a sense we're still using power there, because diagnosis is what brings funding with it within the NHS. Are we then saying that someone else must diagnose in order to bring the funding for our therapy? They're then exercising the power, and are we perhaps abrogating responsibility because we simply don't like diagnosis? Or can we do something more complicated, like formulating, finding out where the person sits, thinking about what interventions will help the person alongside that person, and then thinking about which diagnosis best fits that, in order to provide the resources, to provide the intervention that the person wants. Okay. We need to think about the person in their context. So we don't just use power on an object, we use it on a person. And that's that biopsychosocial spiritual approach, which encompasses the whole of a person, rather than simply just this sort of illness model or the sort of broken person model or something like that. It's a whole person in the world, in the social world. We need also to be aware of the position of ourselves within that. Not as the central driving force in the person's life, because I'm such an absolutely amazing counselling psychologist and they're going to be oriented to me entirely. Because that's a form of arrogance, but it is a form of arrogance that I think it's easy to fall into, where we think that because they come and see us in our consulting rooms, that our life and their life exists in the consulting room. Of course it doesn't, it exists far more widely out there in the world. And as I've said, we need to incorporate social, psychological, and spiritual with the biological. We need to think about a whole variety of models without losing any of those, because if we lose any of those parts, we lose a part of the person. So human minds are not broken machines in a void. Human minds are part of human beings, are part of society and wider elements. But in that, as counselling psychologists, we can still use power. We can diagnose, and we can formulate and diagnose. We can push for formulation. If we're in a multidisciplinary team meeting and our colleagues who have a medical background are using diagnosis, well, we can be respectful of that, certainly. But we can also say, well, look, there's another way of looking at how this person's life and how this person's difficulties all fit together, and we can push for that as being the way of recognizing the person. Now, of course, if you're going to do that, you need to know what the diagnosis is and what it means. Because if you're going to argue against something, you need to know what you're arguing against. You can't just make a blind critique. So imagine a room where everyone was talking about formulation and a psychiatrist was patronizingly shushed for talking about diagnosis. I'm not suggesting we should patronizingly shush our psychiatric colleagues, because they do a very hard job and they're very clever, compassionate people as a rule. But that idea that we pipe up about formulation and it's sort of seen as a bit silly, I think is something that can be challenged, because it needn't be. I think there are different ways of looking at the world, and we should have the strength and courage to foreground our way of looking at the world. We hold a doctoral level qualification, and that means that we can supervise a whole variety of other staff members. We can supervise clinical psychologists, medical psychotherapists, counsellors, nurses, psychiatrists. We can hold management, team leadership roles. We can hold budgets, make decisions, have advanced and expert knowledge. Now, I'm a consultant psychologist, and so obviously these things fit within my remit. But when you gain your doctorate, at that point, you have advanced and expert knowledge. Just as someone will go and see a medical doctor, and they may be a relatively junior medical doctor, they won't be a consultant yet, but they will be asked to make decisions, they will be asked to evaluate things, and they will be able to act with their own power within that. So we too should be foregrounding our power when we hold our doctorates. We shouldn't be afraid to assert that power in our client's interest. We should use our doctor. It's not uncommon, for example, that I have had a GP who hasn't used the client's correct name because they've made a change of gender role and they've made an appropriate change of name, and very reasonably they want to be called by that name. And the GP has, for some reason or other, said that they are not going to do so. And so I write to the GP and I say, Dear Dr. X, I wonder if you'd be so kind as to do this. Here's the relevant guidelines. Yours sincerely, Dr. Christina Richards, etc., etc., etc. So I'm using my power there. I'm using my doctor. I'm using my stuff, if you like, and I'm using it on behalf of my client. And that's what I think we all should be doing. We shouldn't be afraid to advocate using our power on behalf of our clients. Silence is something which we also trip over. Silence is really important in the therapy room. Silence creates space where the client can fill. Silence creates an opportunity for something to grow out of in the therapy room. And of course, in the therapy room, what's needed is for the client. Outside of the therapy room, if we're in a meeting, what's needed is for us as professionals to fill the space. If we create silence, someone else may well fill that space. We need the judicious use of silence, the judicious use of power. We should be aware that the vacuum of our silence outside of therapy will seldom create space for thought or a place for listening. Instead, it will be filled by a psychiatrist or a manager coming from a different worldview who may make problematic decisions while we stay quiet. We mustn't be afraid to speak up with our knowledge base and our understandings. It may be that the psychiatrist or manager has a very good point, and so we wish to listen to them and we wish to echo or foreground their point. That may be wonderful. But it may well be that we wish to make a point also. We have to be very cautious of our silence, because if we are silent, others may fill it and our clients may suffer. It's important for us to be able to foreground intersubjectivity, to foreground our I-thou, our compassionate approaches, to foreground the personhood of the people that we're dealing with, because this is our bedrock. And if someone else is looking at budgetary constraints, or if someone else is looking at a diagnostic framework, or if someone else is looking at something that doesn't sit right with us, it is incumbent upon us to speak up in those circumstances. We need to engage with people. I'm worried a little bit about how we actually engage with people who are open about experience of mental distress. I'm aware that we don't, as a rule, have a stream in the conference, for example, for people with that. I'm aware that we don't, in CPR, have a stream for that. I'm aware that within counselling psychology training, we don't always have people with direct experience of mental distress come into the training room. I'm aware that there are a number of times when we pride ourselves, and rightly, I think, about our compassionate approach, but people aren't always in the room. They're not always co-producing. Sometimes we consult, we have stakeholders, but we don't always co-produce. I think maybe we need to do something about that also. Where is our outreach? I think this is a really important point. How are we bringing the people that we claim that we are intersubjective with into that intersubjectivity? We need to do consultation and we need to do activism. It's not enough just to sit in the room with people and talk with an individual. Again, we need to exercise our power within other circumstances. We need to talk to the government. I periodically go to the Government Equalities Office, for example. I engage with my MP. I engage with a variety of other governmental organisations, also third sector and the NHS, but at a strategic level. And I do that again as Dr. Christina Richards. I do that again with expert knowledge. And I tell them facts. Now, of course, here at a conference, we'll have debates and we'll talk about those facts and we'll come to some further opinions and further understandings, and that's absolutely right and proper. But when you engage at a strategic level, it just doesn't work because they think, the people don't know, they don't know what the case is yet, I'll find someone who does know. And that's where the resource goes. So it's really important that we present the facts as we know them in simple and bite-sized pieces so that people can then act on that, give us resource, and then when our thinking evolves, we can then go and evolve that thinking that we bring to government, and then we can get different resource. We also need to tell people things to do. So policymakers aren't really interested in debates. What they want is, here's the fact, here's what you need to do about it. And with the child mental health crisis, for example, at the moment, I think it would be a really timely opportunity to say, here's what's needed, and here's what you can do about it, to policymakers, to government. We need to work more with communities. We need to build bridges from our ivory towers and our cushion therapy rooms. And we need to experience a wide variety of cultures and subcultures. Again, if we claim that we are able to deal with a wide variety of people, it's not okay just to see them in the therapy room. We need to go out and hang out with people, spend time with people, out there in the wider world. I think that's a really important way of engaging. So, for example, today is London Pride. And going on London Pride, showing support would be a wonderful way of just going and being with a whole load of LGBT, QQI++, gender, sex, relationship, diversity people, rather than saying, well, I'm open to people, or that we welcome them into our therapy rooms. There's something uneasy in terms of power about that. In teaching, we need to teach facts as well as theory. We teach a lot of theory. We don't teach that many facts as counselling psychologists. And as I said before, if we're looking at diagnosis, if you're going to argue against diagnosis, as many counselling psychologists do, you need to know what the diagnoses are. I wonder how many people are familiar with the revised ICD-11 diagnoses that have just come out. Because that's an important thing. If we're going to say we don't like diagnoses, we don't know what the current diagnoses are, how do you know you don't like them? We need to equip students to make decisions. I have a colleague of mine who is a junior doctor. The senior registrar wasn't available. The consultant wasn't available. There was an unconscious patient on the bed. She was going to die, and the nurse said, "What do we do, doctor?" And my colleague had to decide which medicine to give the patient, in the full knowledge that she may give the wrong medicine and the patient may die. She gave the medicine, the patient was okay. But in that moment, that was the sort of crucible in which she became a doctor, where she was able to make a decision. She was able to put pen to paper and say, yep, I'm responsible for this outcome. Now, actually, we make very, very important decisions within therapy, and we make very important decisions outside of therapy if we're doing child custody arrangements, for example, if we're making Mental Capacity Act assessments, if we're doing a variety of other things. And I think we need to make sure that students don't feel able just to talk about things, but to say, this is my recommendation, and to take responsibility for that. In clinical work, we need to do focused and open-ended work. I think sometimes in counselling psychology, we have an idea that a lot of work is open-ended, and we sort of cram in focused work. We're not very good at the model of focused work, of time-limited work. And of course, time-limited work is itself necessarily limited. It's not got the opportunities available in open-ended work. But I put this example up here, condoms do reduce the risk of STIs, because I ran a psychotherapy group, and they started talking about whether condoms reduced the risk of STIs. This was a very limited number of sessions we had available to us. And I said, 2 ticks, they do. They absolutely do reduce the risk of STIs. Now, what does that mean in terms of whether you want to use them or not? And there was a very fruitful discussion then about relationships, about trust, about what it meant to use one or not to use one. And actually, there was the meat of the discussion that was had. Now, they could have continued to discuss whether or not they reduce the risk of STIs, and just for factual, they do. They really, really do. They could have continued that discussion, but actually, something useful may have come out of it. But it also may not. They may have got through 4 sessions, come to the conclusion, yeah, they probably do, and not really got anywhere. Now, of course, as I say, I've used my power to limit the opportunities for discussion. But I think, given the resources that were available, they had a more fruitful discussion because I went in there. So I think we need to be very cautious about just assuming everything's open-ended, that anything that people bring needs to be unpacked to its fullest extent, that we can't guide things if we have limited resource. I think that's a model which comes from a much wider available resource, perhaps a little bit more of a historic model. And I can tell you that in the NHS at the moment, doing the strategic and budgetary work that I'm doing, it's just not going to fly. We need to make sure that we can get the most possible for our clients out of what we bring. We need to be evidence-based. That's fine. But of course, we don't always have the evidence for the things that we know in our gut work. We need to be philosophically based if we're not evidence-based. I'm not sure it's okay just to say, well, my gut says it's all right, because there's been a lot of bad stuff happen from people's guts. And we need to be logic-based. We need to work out, okay, this, then this, then this. And then that's defensible practice. That's practice that we can bring through and that we can defend when we're looking for resource, or indeed if there's any difficulties. And we need to make decisions which are in the client's best interest, if at all possible, along with the client. Now, when I say this, there's often a little bit of a rustle, because people read it whichever way they want to read it. Let's read it again. We need to make decisions which are in the client's best interest, if at all possible, along with the clients. Now, almost invariably, it will be along with the clients. But we have some clients, those who are very, very psychologically unwell, for example, or those who have a very significant learning disability, where actually in some cases they're not able to make decisions, and we need to assist them and we need to make decisions for them. And of course that needs to be in the client's best interest. But again, there is that use of power, and we are kidding ourselves if we think we're not using power under these circumstances. Thank you very much.
Yeah, that was fantastic, Christina. Short and very sweet, I might say. Why do you think that we are so... I was very struck when I was doing my counselling course. Someone said, you're very powerful, Ben. You need to be very mindful of your power. It's that whole with great power comes great responsibility thing. Why do you think we're, as counselling psychologists, we're so shy, really, about talking about some of the things that you said today?
So I think we equate power and speaking up with taking people's voices. I think we think that if we speak, someone else doesn't get to, and that's necessarily problematic. My feeling is that it's about judicious use of that. It is that if I'm yakking on and my client therefore can't speak, I'm not acting correctly there, I'm not doing well. But if I'm in a meeting and, well, for example, I was involved in a set of guidelines, writing a set of guidelines, and they were written with the word physician all the way through. And I said, whoa, hang on a tick, before you sign them off, change that to clinician, please. And they did. And that meant that psychologists were able to take all of those roles, rather than medical doctors who were physicians. So I jumped into the middle of a meeting and just got everyone to shut up and said that, and the knock-on effect was huge for that. Now, had I sat back, given space, had time for reflection, it just would have rolled on, and there would have been a real problem, because for that quite large client group, they would have only seen physicians. They wouldn't have then seen any of the psychologists who could have sat down and done a different piece of work with them. So I think it's about, I think we misunderstand that speaking up and speaking out is not taking space. Sometimes speaking up and speaking out is creating something that's got space in it, that's more equitable.
Hi, I was wondering, do you have any guidance for trainees like myself who, for ways we can sort of practice and grow familiar with exercising our power when we might be in situations where we might feel powerless? For example, being a trainee on, say, the bottom rung of a ladder of a placement, for example. So,
and that's an excellent question. I think sometimes it's about recognizing where our power lies. So it really depends where you are as a trainee. We say trainees, and some people start their training when they finish their undergraduate degree. Now, if you've finished your undergraduate degree and you're in a room with some medical doctors, you know more about research than they do, almost invariably. So there where we're like, can we speak up? Yeah, about research, sure. About medicine, no, absolutely not. They are the experts in there. So knowing where your power lies. Having said that, a lot of us as trainees have done other things. So many people as trainees have done PhDs. And then you absolutely speak up about research, because there will be relatively few people in the country who will know more about research. And about your topic, there will be no one who knows more about it, almost necessarily. So knowing where our power lies and then speaking up is important. Also, bear in mind that if what you want to say is backed by the BPS, or is backed by a Cochrane review, or a big meta-analysis, while you're voicing it, it's not you who's saying it. So it's okay to say, well, hang on a tick, to a whole bunch of very experienced colleagues, the BPS has published a position statement on this, and the BPS says X. And then you've got all of us shouting behind you, saying, no, stop, this is what we reckon. So you can use power in that way as well. You can speak up in that way. It's not just us as people. Sometimes I think there's a wonderful episode of The West Wing. There's many wonderful episodes, but there's one particular episode where President Bartlett meets his old priest, and the priest says, "Do I call you Jed or do I call you Mr. President?" And he says, "Mr. President, please. It helps to think of it that I'm doing the job rather than the man." And I think actually there's that as well. And I find that, I use my Dr. Richards when I'm at work. And the reason for that is because I have to make some uncomfortable decisions sometimes. And it's far easier for Dr. Richards to do that than it is for Christina to do that. Christina might make a decision which feels right because I have a particular history, but may not be the right thing for the client. There may be too much of me in there. I'll check in with Christina to make sure I'm not being an arse, absolutely. But fundamentally, it's Dr. Richards who's making those decisions, and it's Dr. Richards who has to justify them. And I think that's right. I think we need to recognise that power, that I don't just go in and be Christina, because you know what? Sometimes I like to watch TV in my pants. It's not okay. Stop the video. No, it's not okay to do that with a client. That's what Christina does. As Dr. Richards, I have to be Dr. Richards, and that's right. That's what's called professionalism, right? So it's okay to foreground that.
I was struck by something that you had at the end of a slide. You didn't particularly say it, but it was implicit in what you were saying previously, which is to make trainees or students aware at the point at which they graduate or as they come to graduate of the power that they hold. Yeah. And I'm just kind of struck by, I wonder whether you think that there's a particular role for the DOCP that is separate from the training institution and the placement, because in my own experience, that wasn't really the training the training institution was about the theoretical and the understanding and the mind somehow, and the practice sat in the placement, but that bit in between, which you refer to in terms of the understanding and the exercise of power, I wonder whether there's something that the DOCP is uniquely placed to try and make evident.
Yeah, I think we certainly need to foster it. And I think we can foster it through engagement with the division, through our publications, through wider engagement certainly with the BPS, with the HCPC, with the NHS, with the governmental organisations, all of those sorts of things. So I think we need to foster people to do that. But I think it should start from day one on training, that you are a person who is going to wield and exercise power. I think it's something that we really need to acknowledge and need to have woven into the training. That's not to say that we should encourage people to sort of stroll in and say, you need to do this, you need to do that. We need to be aware of power, sometimes to mitigate it, sometimes to equalise it, sometimes to say, no, I'm not going to equalise it, I'm going to use my power, but to use it with your eyes open and judiciously, whether that's with the government to say, well, I'm an expert psychologist and we need to put more money into X, or whether that's with a client where we say, look, we've got very limited time, we need to focus on these particular topics, or we need to co-construct some topics that we're going to focus on. We need to have that woven through our courses, I think, that we're able to do that.
Hi, what drives your passion for and in counselling psychology?
Sorry, I didn't catch the very last bit of that.
In counselling psychology, what drives your passion?
What drives my passion? So, I guess I'm a fairly passionate person about lots of things. In counselling psychology, I am particularly passionate about sexuality and gender. That's my particular area. Partly because there's so much intersectionality. So there's something about ethnicity, there's something about obviously sexuality and gender, there's stuff about our religion and faith, and all the sorts of aspects of humanity, and then all the different aspects of professional practice. So psychology, psychiatry, endocrinology, surgery, law, and then the intersections with activist communities who've done some of the most important work in the area. So that's the sort of my professional sort of interest, particularly as it pertains to counselling psychology. I think, as I was saying earlier, applied psychology, and perhaps particularly counselling psychology, has this unique perspective where we are not counsellors who do very important work sitting in a room intersubjectively with people, and we're not medical people who have quite a reductionist natural sciences approach of diagnosis and treatment, but we sit somewhere in between those, which is quite an awkward and uncomfortable place to be, but perhaps maybe the right place to be, actually, that we're not kidding ourselves about power, that we do use power, but also we use it in a way which is intersubjective, which recognises the humanity of the person. So that's where my passion lies. It's a difficult and messy place to be, but in there is something actually quite precious and important.
If no one else is going to... Excuse me. If no one else is going to ask a question, Christina, can I ask you a question slightly... Well, it incorporates your topic of power, but also as the incoming chair, I wonder if you could speak to how you'll use your power as incoming chair in moving DCoP forward, or what your ideas are, if you can.
Yeah, so, I mean, I guess the thing about being chair of something like DCoP is it's very much a first among equals thing. So it's not an executive position. It doesn't carry with it executive power. Having said that, it is a position where I have implicit power in that I get to talk when other people don't. I get to organise meetings and other people don't. I get to sort of do a lot of stuff. And I guess that's sort of what I'm saying. You know, I don't want to stand here and say, oh, well, as chair, I don't have any power, because that's wrong. But equally, what I don't want to do is say, well, you know, I have executive power and I can make stuff happen. It's about that messy tension, that complexity. In terms of my aim for DCoP, you know, to an extent, what I've just presented is a manifesto for where I think people can be. I'm not saying that everyone needs to immediately do mental capacity act assessments or something like that, but I think we do all need to be aware of our power, and I would love to see people in meetings or on television or at government or in a variety of other places say, hold on a tick, I hold a doctorate in counselling psychology, and my view is this. I think that would be really useful, because that would affect change in a way that actually I think we all would like to see. Because at the moment there are some strong voices out there, but they're not always our voices. And that means that different ways of looking at the world are being foregrounded. So in the various ways that I can influence things and that I can exert power as chair, I think that's what I'd like. I'd like us to know who we are, right? And to put who we are out there. I think that's what I'd like. But I'm open to other people telling me, of course, you know, what they would like. That's the primary purpose. And heavily tip. That's important too.
Hi, thank you. Yeah, I was impressed with the emphasis on people with lived experience, and having been to Lucy Johnston is arranging a lot of the disorder for everyone across the country. I don't know whether people have come across that sort of goes against the medical model and that kind of thing. And I think there might be some benefit in, you know, joining up with some of that, maybe, from DCoP's perspective. I don't know what your thoughts are on that.
Yeah, absolutely. You know, I don't think we need to do this in a silo. I think we need to engage with as many people as possible. Absolutely, yeah. And you know, very much like Johnson's work. Peter Kinderman's done some great work in that stuff, as have a variety of other people. So I think, yeah.
Hi, I just wanted to thank you really and just reflect on something that resonated with me. I think maybe during the training process there's a lot of sort of assimilating this neutrality, so it was quite encouraging to hear from you that it's perhaps not enough to sort of sit in a room and say, you know, I'm open to this community and I'm open to that, but actually maybe be out there and demonstrate it. So thank you very much for that.
Thank you. Yeah, absolutely. No, I think that's right. I think that sort of I'm open to things there's a certain arrogance that can be associated with that simply being in my presence is somehow healing. I don't think that's okay. And there's also this idea that somehow because I'm open, I'm a good therapist. Well, of course you should be open. I mean, why would you not be? That doesn't make you good. That's like your baseline zeroth rule for being some sort of therapist. So I think we need to, we need to make sure that we're actually out there learning stuff, being with people, recognizing power, exerting power on behalf of people, being informed by people with direct experience, co-constructing with people with direct experience. Just sort of, being, I guess just being open is not enough. It's just not enough. I guess if you're a brickie, if you sat there like, well, I'm open to the idea of buildings and walls, that's like, that would, that's great. I hope you are, but we're going to need more. All right, well, my email is up here. Drop me an email if you have any thoughts, if you want to talk to me, if you want a coffee. I'm chair for everyone, and I'm open to all discussions and all thoughts. Thank you very much indeed.
Thank you, Christina.